All right. Good evening, everyone. I hope that everyone can hear me loud and clear. My name's Jason Roberts. I'm a pharmacist from the University of Queensland, the Royal Brisbane and Women's Hospital, and it's my pleasure to welcome you to this webinar. This webinar is coordinated by CRE REDUCE. That's the Centre of Research Excellence for Redefining Antimicrobial Use to Reduce Resistance. Hence, you can see why we abbreviate the name. We've got an excellent topic for you tonight. It's part of our masterclass webinar series, which is focused on evaluating the potential role and how it can be expanded, specifically for outpatient parenteral antimicrobial therapy. We have some excellent speakers who will be participating tonight, and it'll be my pleasure in a moment to introduce Dr. James Pollard, who's from Cabrini Health, who will be the chair for this evening's webinar. Before I hand over to James, I just wanted to acknowledge our sponsors who make this webinar possible. MSD, Pfizer and Baxter are great supporters of this webinar masterclass series, of which there will be 4 throughout 2020. And even in the context of the challenges that the COVID-19 pandemic has provided for all of us, they've provided some excellent support to us to allow us to continue to provide these excellent topics, which I hope that you will find are indeed informative and useful. So with that, I'll hand over now to Dr. Pollard and allow him to introduce the speakers. I'll just stop my share and pass over to James.
Thanks, Jason, and welcome to everyone who's attending. We're up to nearly 100 attendees already, so it's fantastic. Welcome, everyone. It's a great pleasure to be able to be the chair tonight and to facilitate your questions later in the evening. At this stage, I'll remind you, if you've got formal questions as the speakers are speaking, if you use the Q&A tab for us, then we can collate them and it'll be much easier for us to put them directly to the speakers later in the evening. We have got plenty of time for questions, so we welcome them. We have a pretty diverse audience, so we've tried to pick the topics that will appeal to most of you fairly well. However, we're aware that it is quite a diverse audience, and if things are unclear, please sing out in the Q&A for us. For those of us that have worked in OPAT or hospital in the home for an extended period of time, endocarditis is core business. It's a huge relief on our health system, getting people out of physical beds and treated at home. But with that comes a number of caveats on patient selection, patient progress, and the evidence over the journey says the patient outcomes are very good. So with that in mind, we're aware that there are a number of issues around use of intravenous antibiotics in the community, and we're very pleased to be able to put together this selection of topics for you. At this stage, I'll introduce Dr. Yong-Shen Wee. Dr. Yong-Shen Wee is a general cardiologist from Prince Charles Hospital in Brisbane and is a senior lecturer at the University of Queensland, co-chair of Infective Endocarditis Queensland, and a co-investigator of the POET2 trial. And we're very pleased to have Dr. Yong-Shen Wee share with us on infective endocarditis treatment and preparing for OPAT. Yep, the full screen was good, and just unmute and you're good to go. So if you start show, we'll be able to see that, and just unmute and you're ready to go.
Good evening, ladies and gentlemen. Can everyone hear me? Hello, yep, okay. So I'm Dr. Yong Wee, a general cardiologist from Prince Charles Hospital, as well as co-chair of Infective Endocarditis Queensland and co-investigator of the POET2 trial. So I'm just going to start off by giving a basic layout of my presentation today. I'll start off with introduction to infective endocarditis, and give a bit history and the present, diagnosis, basic principle in treatment, including consideration for home IV therapy. So the introduction basically start off with infective endocarditis is the inflammation of the inner lining of the heart or endocardium and regularly involve the valve of the heart. It developed in 3 stages. The first stage is bacteremia, which the microorganisms are present in the blood, which may originate from the distant infected site or obvious portal of entry such as intravenous drug injection site. The second stage as shown here is the adhesion, where the microorganism adhere to abnormal or damaged endothelium, as you can see here in the picture. Lastly, the third stage is the colonization, which involves proliferation of the organism together with inflammation, leading to the growth of vegetation, which is what we can see on echocardiogram. And what is the true incidence of infective endocarditis in the developed countries? According to the above 3 publications, in the general population is about 3 to 14 cases per 100,000 per year. That translates to about 10,000 to 45,000 per year in the US and 750 to 3,500 per year in Australia. However, if you look at different subsets, the incidence are slightly different. In the elderly population between age 80 to 89 years old, it's about 70 per 100,000 per year, whereas in people who are considered moderate risk population, it's about 230 to 280 per 100,000 per year. Whereas in the high risk population, is 870 to 1,380 cases per 100,000 per year. So it's slightly different, and the risk is the important part here. According to our experience at the Prince Charles Hospital, we receive about 60 to 80 cases per year, which 30 to 40 cases proceeding to surgery. And after having a chat to our finance department, they gave us a breakdown of the cost, and it's divided into 3 categories as shown here. 37,000, about 11,000, and 7,000. The 37,000 are those that require high care, such as ICU, as well as all surgery. The 11,000 are generally those that involve only ward care only. The 7K are those that we manage to discharge the patient for hospital in the home treatment. So as you can see, hospital in the home treatment save about 3K per admission. And if you multiply by the amount of patient that we manage to send home, there's quite a bit of saving. Now we move on to the history of infective endocarditis. And the definition of infective, the past and present, basically just a quick definition, is only roughly, it's between 1550 to 1970 for endocarditis past, whereas endocarditis present is from the 1917 till now. We start off by this picture showing microscopic section of the heart valve, which is the first published report of bacteria in vegetation, which leads to the start of our study of infective endocarditis. And this is the famous Dr. William Osler, which Osler note is named after. He published and gave extensive lectures on infective endocarditis and has been heavily referenced in future lectures worldwide. This is another pictures published in the Practitioner 1905, showing Dr. Thomas Hodder showing techniques of blood culture in London. In 1945, Kelson SR published in Internal Medicine 1905 regarding the prognosis of untreated subacute bacterial endocarditis from 1927 to 1939. Unfortunately, only 1 out of 246 patients survived. Average survival was only 5.9 months, and a mere 7% lived more than a year, and the longest survival was 19 months. Luckily, that was the past. Now, let's move on to the present. The transition to endocarditis present was revolutionized by antibiotic treatment starting from 1944, surgical valve replacement starting roughly in 1965, and the increasing use of echocardiography from 1973. The first subacute bacterial endocarditis case treated with penicillin in UK was in 1943. It was a 24-year-old male with strep viridans on a septal defect. He was treated with penicillin over 30 days by Dr. Flory, but unfortunately that failed. The next year sounds a bit better. It was a first publication of successful antibiotic treatment of infective endocarditis, published by Louis et al., where he had 7 patients treated with penicillin and all 7 recovered. In 1965, Duke University published the first success of treating infective endocarditis by valve replacement in a 45-year-old man with acute endocarditis on the aortic valve. And the invention and widespread use of echocardiogram in 1973 also revolutionized the management of infective endocarditis. As you can see on the top picture, the initial echocardiogram machine essentially filled a whole room, so it's not very portable. Whereas nowadays, as shown in the picture at the bottom, we managed to get good quality image, if anything better than the machine up there, on a laptop-sized echocardiogram. And lately, there's a few smaller machine coming out, the size of an iPhone. And technology for echocardiogram also moved on since the beginning. Initially, when echocardiogram was invented, there's only M mode, as shown in the top left-hand corner. And then this moved on to what we are familiar with now, like 2D echocardiogram. And lately, in the last few years, we have been increasing using 3D echocardiogram, with the image quality improving every single year. Now we'll move on to the diagnosis of infective endocarditis. The initial Duke's criteria was published in 1994, but this was modified in 2000. So the modified Duke's criteria was 2 major, which include typical blood culture or evidence of endocardial involvement, or 5 minor criteria, including predisposition, fever, vascular phenomenon, immunological phenomenon, and suggestive microbiology. To have a definite diagnosis, you require 2 major, 1 major and 3 minor, or 5 minor. If it does not fulfill the above criteria, it could be possible infective endocarditis or other causes. And Storm et al. Published an Internal Medicine in 1998 on the risk factor on infective endocarditis with prosthetic valve surgery odds ratio about 75 at the highest. Previous endocarditis is about 40. Rheumatic fever, mitral valve prolapse, or any valvular disease is around 20. Congenital heart disease is at about 6 to 7. The dental procedure or dental hygiene is actually quite low on the list, between 1 to 2% only. IVDU is not on the list, but it's felt to be about 30 according to other publications. So echocardiogram criteria for endocardial involvement is defined here. It's basically defined as vegetation, abscess, new partial dehiscence of prosthetic valve, increasing valvular regurgitation, valve perforation and aneurysm. There was some recommended addition and deletion as shown here. according to the 2015 ESC guideline. So this is a publication from us by Dr. John Setridge and Dr. Burstow about the sensitivity and specificity of transthoracic echocardiogram and transesophageal echocardiogram on native valve, and showing the sensitivity and specificity of vegetation and abscess. As you can see, the sensitivity for POE for vegetation is about 92 to 94%, but for abscess it ranged quite widely from 36 to 87%. Whereas for specificity, it's more than 90% for all of them. Whereas it's slightly different on the prostatic valve. So this is the same thing, but for prostatic valve. And as you can see, for the specificity, the transthoracic echo is only about 64%, whereas TOE range from 85 to 100% for vegetation, and it's still more than 90% for abscess. And just to go through quickly some predictors of poor prognosis in echo finding for infective endocarditis, basically periannular complication, large vegetation, severe left-sided aortic regurgitation, severe prostatic valve dysfunction, reduced EF, pulmonary hypertension, and elevated LV diastolic pressure. And there's some red flag we look for that require further assessment, basically poor quality images, pre-existing degenerative valve disease, new native valve regurgitation in comparison to previous assessment, any prosthetic valve or implanted device, unexplained anatomical abnormality, and abnormal hemodynamics. Habib et al. Published in the European Heart Journal in 2009, basically just a table or graph to guide us on when to move on from transthoracic to transesophageal. Basically, any prosthetic valve intracardiac device poor quality image, as well as if the transthoracic is positive, we move on to the transesophageal. Whereas for the negative one, it all depending on the clinical suspicion. If the clinical suspicion is high, then to proceed for transesophageal. Despite a negative transesophageal, if the clinical suspicion is high, is to repeat the transesophageal within 7 to 10 days. And there's also other imaging modality that's involved. This is another table that shows that what other images or what other imaging we could use. So for the definite infective endocarditis, is to consider further imaging for detection of complication or surgical planning by organizing either a cardiac CT or CT MRI. Whereas for possible infective endocarditis, further investigation can be done with a cardiac CT, PET, CT MRI, or a repeat transesophageal echo to further define the diagnosis of infective endocarditis. So this is basically a meta-analysis of PET scan in infective endocarditis, which involved 13 studies with 537 patients, and it is useful for diagnostic purposes. This is also stated in the guidelines in the 2015 ESC guidelines, as well as you can see on the top here, we wrote a letter to the editor regarding nuclear imaging in the diagnosis of infective endocarditis, where Dr. Joseph Sleeve is one of our nuclear medicine directors. Just some pictures, colorful picture. Oops, sorry. Showing PET scan. As you can see, all this lights up is where the infection are. So move on to the last topic that I'm covering before I hand over. Basically, the basic principle in treatment, which also involve consideration for home IV therapy. So the main thing we'd like to reinforce actually with our infective endocarditis Queensland is teamwork. I mean, we've been doing that with our HITH meeting, where we involve multidisciplinary team, including cardiologists, cardiac surgeon, ID physician, intensivist, imaging specialists, neurologist, neurosurgeon, hematologist, as well as allied health personnel when required. So just so basically the treatment of infective endocarditis. I hope this doesn't overlap too much with what Lydia is talking, but basically stage 1 is to clear the bacteremia, which usually happen between 4 to 48 hours. Stage 2 is to reduce the number of microbes from many to a few. Usually that take about 2 to 4 days. And finally is to kill everything else, which can happen from 10 days or more. And there are three very different types of cure for the definition of cure for infective endocarditis. The first one is microbiology cure, which all the microbes are dead, which technically is relatively easy. Whereas from the patient point of view, I guess when they feel well or when they're back to normal, it's not so straightforward, but at least cardiology cure is one of those that impossible, because I'll explain next. So the reason is that pre-existing risk factor for infective endocarditis usually still exists, secondary to like congenital heart disease, some bicuspid aortic valve, valvular lesion, poor dental hygiene, or IVDU. And with infective endocarditis, there's a high chance the paravalvular damage still exists. And then nowadays, with a lot of new device that we are putting in, like TAVI, mitral clip, the prosthetic valve replacement is still there. And previous infective endocarditis itself is a risk factor for recurrent infective endocarditis. And just to cover a little bit about the slow response of antibiotic treatment in IE. So basically, it happens in this few scenario, very high count of bacteria in vegetation, or sometimes most bacteria in vegetation are in stationary growth phase, and absence of exclusion of host defenses like leukocyte could be another reason. And then endocarditis is a variant of biofilm, actually on the devices that we put in. And there's also variable penetration of antibiotic into vegetation. Foreign bodies like TAVI and a few other devices that we put in could damage endocardial surface, promote coagulation and formation of sterile mini vegetation, and increase the susceptibility of infection by blood-borne bacteria, increase abscess formation, development of biofilm again, a risk of antibiotic failure, and the need of surgical intervention. I'll skip this one. So just to quickly mention about surgery for endocarditis, as this is not the main topic for today. Basically, the indication is heart failure, uncontrolled infection, and prevention of embolism. And we usually can divide this into like emergency surgery, urgent, or elective. So lastly, I'll just mention briefly about consideration of home IV therapy. These are the guidelines that appear on therapeutic guideline, which is mainly used by at least majority of the hospital that I'm aware of. Basically, we go through this checklist, which I'll show you next. Like patient need to be medically stable, and also there should be appropriate intravenous antimicrobial regimen that is able to be administered in a community setting. This needs to be assessed by both doctors and nurses who are responsible for the patient. And home or other treatment environment must be suitable as well for both the patient and the visiting staff. So usually there will be a home visit prior to planning the home antibiotic. In the IVDU group, or alcohol misuse, basically it's not a total no. It needs to be considered on a case-by-case basis. and careful counseling about the hazard of vascular access manipulation is recommended. And if there's any concern patient is misusing it, then the treatment should be stopped or need to be discussed at least. So this is just a form that Metro North, which includes the Prince Charles Hospital, as well as Royal Brisbane, that we go through this checklist, and then it's discussed in the MDT meeting before we decide whether a patient is suitable for home antibiotic. And this is just a publication that came out from the Royal Brisbane, basically about IVDU, and the conclusion that it's reasonably safe from both the patient as well as from the staff point of view. So just a bit about our infective endocarditis Queensland. Basically, it was established about 3 years ago, and we try to involve multidisciplinary team, and we currently have a HITH meeting, which currently mainly at Prince Charles Hospital, but we are hoping to extend to statewide in Queensland, and hopefully in the future nationwide. Everyone is encouraged to join, and it's on the website. If you Google infective endocarditis Queensland, there should be a Queensland Health website that you can access. Also, just to quickly mention is that we are planning to host a IEQ research day, depending on the COVID-19 situation, obviously, but currently it's being planned for about October 23rd. If you are interested, do keep that in mind and just keep an eye with the website. We'll update you all accordingly. And lastly, sorry, just to mention POET too. Basically, we are the leading Australian site for the POET 2 trial, which is run by the team who organized the POET previously in Denmark. Other hospitals are strongly encouraged to join once the governance and ethics is complete. And worldwide, we're expected to have about 700 participants. As part of this trial, we are also planning 2 sub-studies involving the same patient, comparing molecular or traditional culture technique for prediction of treatment failure, as well as TDM of beta-lactam to predict treatment failure and adverse drug reaction. Further information is on the IEQ website, and we strongly encourage everyone to register at least with us, and any updates we'll send out by email. Thank you.
Thanks, thanks, Dr. Yongwei, for that. That's a fantastic summary. Right, so we may just keep moving along in the interest of time. So we'll let Yong let his screen go, and I'll introduce Dr. Lydia Upjohn. There we go, very good. So Dr. Lydia Upjohn is an infectious diseases physician at Monash Health in Melbourne. Lydia trained at Monash and the Royal Melbourne Hospital and did a research fellowship with the National Centre for Antimicrobial Stewardship at the Peter Doherty Institute in Melbourne. She works in the hospital and the home service at Monash Health, which is the largest HITH, largest hospital in the home service in Australia, and is an ID physician. Lydia also works with the Antimicrobial Stewardship Service at Monash. She's interested in all aspects of clinical infectious diseases, but particularly in antibiotic prescribing behaviour on the wards, improving antibiotic education for both junior and senior medical staff, and teaching how to optimise antibiotic prescribing in hospital. We're very grateful that she could join us to tell us about clinical care and complications of endocarditis in the context of OPAT.
Thanks, James, very much. And I'm just checking that you can hear me. Great.
Perfect.
All right. So some of this might overlap a little bit with your talk, Yong, but I'll just get going and we'll see how we go. And I'd just like to acknowledge my daughter Claire, who's 9 and rescued my slides after they all disappeared off my computer. And she's very tech savvy, and I said that I would acknowledge her in my talk. Okay. So that's what I'm going to try and cover. There is a mass to talk about, and you could spend 20 minutes on each one of those topics, I think. So I'll just keep going. Now, I had a look at our numbers. We have a 200-bed hospital in the home. It's large. It's spread over 4 sites. And I pulled out our diagnoses and numbers for endocarditis there, and you can see that it's about ranging from 6 to 12 patients per year. But then I had a look at that and I thought, actually, that's probably wrong, because we have at least 2 endocarditis patients at Monash on at any one time. And I suspect this is a bit of an underestimate. So I thought I would just quickly run through patient selection, and some of this is being covered by Yong. But on the hospital in the home side of things, we look carefully at who we should put on hospital in the home. And the IDSA guidelines really say that we should select patients who are at low risk of emboli, and low risk of heart failure. And we do not select patients who have abscesses, conduction abnormalities and fever. And that's really all that they say. And the European Society guidelines basically say something very similar, that we shouldn't really consider outpatient treatment in the first 2 weeks, and consider it after that if they're medically stable. And even that, I think, is actually quite a conservative viewpoint. We tend to take on some patients quite early if they're stable and we don't see any signs of complications. Native valve endocarditis, for instance, that's with an easy to treat strep viridans, we would put them on somewhat earlier than that if they're doing very well and we're confident that then that they don't have complications. And we always think about predictors of poor outcome, and we see this in our patients. The patients who tend to do badly, who we try to watch more carefully, are those who are older, have prosthetic valve endocarditis, have comorbidities and have heart failure and renal failure. And they're the ones that we do put these patients on hospital in the home commonly. We do see that, but we watch them more carefully. Yong, you covered this too. There's the concept of in hospital in the home and endocarditis care of the endocarditis team. We do not have a formal endocarditis team at Monash, but I often feel like we should have one. There's good evidence that a team approach can reduce time to surgery, it can reduce lengths of stay, and it actually predicts survival, and what it's recommended in the IDSA and ESC clinical guidelines on endocarditis. And I think the real key is that it improves clinical decision making and communication. And at the moment, we do this in a somewhat informal way by keeping in contact with our relevant cardiology and cardiothoracic colleagues on the phone and making sure that we're all in communication specifically about difficult patients. But I think it is a good way to kind of formalise plans. And then selection of patients is really key. We go through quite a careful process in assessing patients. We generally have a lot, we try our best to get them onto hospital in the home. We carefully assess their social situation, and we really get all kinds of referrals. We get patients who are homeless who are referred to us for hospital in the home, and we have to figure out where we can accommodate them. We have to make sure that the environment is safe for our nursing staff, and often it is the nurses who will go out to the home. We don't do a home visit before we start hospital in the home, but we do often get surprises about what we find at the home. I think cognition is really important, and it's underestimated. A lot of these patients, I think, have a low-grade delirium, or they're very sick in hospital, and often as we see them serially over their time in hospital in the home and realise that that their cognition is actually improving and that they need kind of careful explanation of what's happened to them in hospital. We pretty much universally require an allied health assessment prior to coming on to hospital in the home, particularly for our older patients, and we carefully question them about alcohol use. Some home situations we find are very interesting, and it's only when the nurses go out and have a look at the home that we really see the full picture. I know there's a whole separate talk on intravenous drug use. At our service, we have close involvement with the drug and alcohol physician and nurse who give us advice on suitability of patients for coming on. We make sure that they're engaged with that service and that they have follow-up with the drug and alcohol service. And we usually require them to come in for clinic visits rather than home visits, which can be a bit frustrating for them, but it does ensure the safety of our nursing staff, which is our #1 priority. Well, I go through quite a process of consent and explanation when I see patients coming onto hospital in the home with endocarditis. We talk about PICC lines, PICC line management, infuser bottles, what they look like, what they can they work, which they usually can, showering and personal care. And I go through the side effects of common antibiotics and what to expect. I talk about nurse visit frequency and timing. And particularly I talk about what to do if they become sick. And this is quite essential for endocarditis care, because you really want to know if they become febrile or there's any change in their clinical state. They need to seek medical attention. And it's interesting because some patients, they really like hospital in the home so much. They like their own bed, they like their own pillow, and they're very happy to be in hospital, and they don't want to come back in if they get sick. And I always talk to them about that if they get a fever, they really have to come back to hospital, and it's really essential that they understand that right from the start. And then I also discuss with them right from the start about echo, if it's needed, when we're going to do it and why, because they all sometimes have ideas about, and expectations about repeat echoes. All right, I thought I'd talk about some of the evidence for outpatient treatment of endocarditis versus hospital-based. And it's quite hard to find good trials, obviously, but there are cohort studies that look at the outcomes of OPAT versus hospital-based therapy. And there was a large multi-centre trial done in Spain that was published last year. It was a prospective study of 2,000 endocarditis patients. And of those patients, 30% received outpatient therapy, so 429, and only 21 fulfilled the IDSA criteria, and they were quite conservative criteria for admission to hospital in the home. And 57% were native valve, 27 prosthetic valve, and 19% were pacemaker-related endocarditis, which I think is probably fairly much what we would see. And the median duration of therapy was 42 days. Half of them had had surgery. And they really had excellent outcomes. So 1 year mortality was 8%, only 1.4% relapsed, and 10% were readmitted during the first 3 months after discharge. And there was no difference when they compared that to the home-based antimicrobial therapy. But you have to take into account that the physicians there will be selecting patients who are suitable to go on to hospital in the home. But it just really shows that of the patients that you are selecting to go on to hospital in the home, they're going to do very well. In terms of Australian data on OPAT outcomes, the study that I could find was this one, 204 consecutive endocarditis cases over 6 years. Of the patients that survived the admission, that was 168 patients, therapy with OPAT was accessed by about half, and it reduced hospital length of stay. The most likely organisms were Viridans group strep, and there were no differences between those who had healthcare associated or community acquired endocarditis. And of note, there was no increase in the risk of readmission, recurrent infective endocarditis or death, which just really reinforces that we are selecting the right patients to go on to hospital in the home, and they're having good outcomes here as well. Okay, so what we really do worry about is complications emerging whilst we are on hospital in the home. Heart failure from valvular insufficiency is said to occur in 15 to 65%, so we always question our patients carefully on symptoms of heart failure. One of the other really worrisome complications is emboli, which really there's no host risk factors that you can really take into account in terms of trying to anticipate which patients were more likely to have emboli. Of course, there's the size of the vegetation and location of the vegetation, but really the risk is mainly within the first couple of weeks, and really within the first week. And you can see from that graph there that after the first initiation of antibiotic therapy, your chance of having an embolic event really falls down quite quickly. So we're probably quite safe when they get to hospital in the home in terms of embolization, but you should always keep it in mind, especially any kind of new neurological symptoms or new abdominal pain to suggest a splenic embolization. So we just kind of carefully watch for that. And then there is the issue of whether a paravalvular abscess is formed or there's some kind of complication. And that I particularly watch for in patients who've got prosthetic valve endocarditis and TAVI's endocarditis, because I think they're the ones mostly at risk, and we ask about fever and we watch their inflammatory markers. So in our hospital in the home, this is what we usually do. We have weekly in-person visits and a doctor review with our patients. Sometimes that is quite logistically challenging for some of our patients, but you know, we do insist mostly that they come into clinic and see us once a week, and we give them taxi vouchers if they do not have transport to get in. And we monitor closely for signs or symptoms to suggest complications or treatment failure. So we look for heart failure, and we look at their fevers, at their temperature chart that the nurses have monitored. And I often get them to actually have a thermometer at home and monitor their own temperatures as well, especially if they've got any symptoms suggest that they might have a recurrence. Any symptoms to suggest an embolic event, we watch their inflammatory markers, and if necessary, we do ECGs if we're worried. But the other really main thing that we do is look for drug side effects. And we monitor their bloods weekly, and we spend quite a lot of time with explaining what's happening and seeing how they're going and getting them ready for discharge. Now, I said that I would talk about duration of antibiotics, but that is a really massive topic on itself to talk about. But I think overall in infectious diseases and in infectious diseases trials and evidence, we are really moving away from long courses of IV antibiotics and doing an earlier oral switch. And the main study that in endocarditis recently has been the POET study, of course, which was a randomized controlled trial published in the New England Journal, which was a non-inferiority trial with 400 patients enrolled. And it looked at uncomplicated left-sided endocarditis. And it enrolled patients for they've all had their first 10 days in hospital on IV antibiotics, and then they were randomized to oral or IV treatment. And it showed non-inferiority. So the outcomes, it was a composite outcome, and it showed that all-cause mortality, unplanned cardiac surgery, embolic events, and relapse did not differ between the two arms. So there is emerging evidence that in those kind of simple, uncomplicated, in left-sided endocarditis, an oral switch is possible and it's safe. They did monitor these patients fairly closely with TOEs, and twice weekly visits in clinic. So that was obviously in a study context, but I think it's pointing us more towards the possibility of being able to use oral antibiotics, which might put us somewhat out of business in hospital in the home, I suspect. Then I thought about what other complications that we look for in hospital in the home. Look, sometimes hospital in the home just doesn't work for a social reason. We have patients who it emerges that they have alcohol problems, or they're grumpy and abusive to the nursing staff, and the nursing staff don't want to go and see them anymore. And I have to get on the phone and talk to them and say that they have to come into clinic, or they start not turning up, or they've just become absent. And so this sometimes happens with our patients, and we just deal with it on a case-by-case basis. Drug side effects are a big issue that we have to deal with on hospital in the home as the treating physicians. And I thought I would just put up a list that I made up of the common antibiotics that we use and what we look for. With flucloxacillin, which is a very common antibiotic and high dose that we use, I always warn the patients about nausea and anorexia. Some patients experience that quite badly, some lots don't, but many do. And mostly you can treat through it because rarely do you want to stop a beta-lactam antibiotic or change their therapy unnecessarily, but I always talk to them about that. We watch for abnormal LFTs, and then their renal function too, watching for interstitial nephritis, and if that develops, checking their urinary eosinophils and arranging a biopsy if necessary. Vancomycin, another common antibiotic that we prescribe in endocarditis. I always watch for cytopenias, nephrotoxicity, obviously. And then ototoxicity and vestibular toxicity. I always ask the patients about that, and I thought about whether there would be any role, because we're giving patients quite long courses of vancomycin sometimes for doing routine audiograms and actually the evidence suggests that there's no role for routine audiograms, and you don't have to do that unless you're worried because someone's high risk for some reason. And then rash and hypersensitivity reactions as well. Carbapenems, LFT abnormalities, rarely seizures or encephalopathy, just something that you bear in mind with those drugs. And then gentamicin, renal impairment, very common. We have to monitor their renal function closely and do levels. So it requires quite a lot of hospital in the home input to do gentamicin well and gentamicin carefully. You have to get those patients in quite frequently. You have to do vestibular clinical testing to make sure that you're not causing any problems with, and that's hard to do well. And you have to be careful that you know what you're looking for. And we commonly stop gentamicin when we see any sign of a toxicity because it's just too hard, and we often swap to an alternative or just stop it. And then cephalosporins, abnormal liver function tests, cytopenias and bone marrow suppression, which often occurs with more prolonged use. And sometimes you can treat, you see their neutrophils going down a little bit and it doesn't worry you too much, but it's really when it gets, less than 1 or there's significant pancytopenia that we stop it. And then renal impairment can also occur, but it's quite rare. In terms of risk factors for failure, there was this study. Look, I've said that, the outcomes are actually very good because we seem to be selecting the right kind of patients. But there was this prospective study published in JAC in 2013, which looked at 80 patients over 12 years. And they said that they actually had a failure rate of 1/3 of the patients, but that included, their failure rate included, not only was it readmission and surgery, it was any kind of drug associated swap or change or side effect. So 1/3 of people, they said, failed. And really what came out in their analysis was that cardiac failure and renal failure were associated with failure of hospital in the home, which is interesting. And I think that's probably the kind of patients that are more complex. And so you can see in their multivariate analysis that it was really the comorbidity of heart failure or chronic kidney disease that really made you do badly. Then we've got PICC lines. That's a whole other issue. You could talk for 20 minutes about PICC lines. PICC line infection is actually pretty rare. It's more common the more lumens you have. So you should always try, if possible, to have just a single lumen PICC. And the rates are quoted anywhere about 1%, 30%. So we don't see it that often in hospital in the home. PICC line thrombosis, we do see. It's, again, not that common, but we watch for it. And generally remove their PICC lines if that happens. And then PICC dressing reactions and dermatitis, that's another whole issue. I warn the patients about keeping their PICCs dry. And then we have sometimes run into this problem of adhesive contact dermatitis with the dressings on the PICC. And usually you can manage that till you get to the end of their treatment. But it can be quite difficult, and we have had patients who've really struggled with it, and we've had to avoid all adhesive dressings and go on to a gauze dressing regime, which has felt somewhat uncomfortable for us, but we have managed to get there in the end. And the last issue really to talk about is the completion of therapy echo, which is a fraught and difficult topic, I think. The IDSA guidelines say that echocardiography is reasonable before or synchronous with completion of antimicrobial therapy, really to establish a new baseline. In our hospital in the home, we tend to look at our cardiology colleagues for advice on whether they think an end of treatment echo will be useful, because the difficult scenario happens is when you see a vegetation or something at the end and you say, well, they've got better, their inflammatory markers have come down, they're doing really well, but we've still got a vegetation on the echo. What do we do with that? Is it just a sterile vegetation, or, but I understand that you can have a new baseline echo so that maybe if they were to get a fever later on, or you're concerned about a recurrence, you would know what the size of that vegetation was. So I thought I'd pull out this paper about the end of treatment echo. may not be needed in all patients with endocarditis. This group looked at 243 patients. 75% of them had an end of treatment echo or a TOE. 79%, so 80% of the patients had no new findings on their end of treatment echo. But if you had new or worsening symptoms, you're much more likely to have a worsening finding on the echo at the end of treatment. So maybe it suggests that really you should reserve it for those who've got change in their symptoms. 3% of the patients without worsening symptoms had an end of treatment echo that required retreatment or surgery. So it depends on your risk kind of setting as to whether you think that 3% is an acceptable risk. And I thought I'd just finish off by talking about COVID-19 and how we treat patients on endocarditis. I think COVID-19 has really changed the way hospital in the home works. We're very careful about asking our patients about symptoms to suggest that they might have COVID, and it's changed the way we get patients in for clinic visits in particular, and increased our use and familiarity with telehealth a lot, which I think has been a really good thing for our patients, and particularly because we're in a good position with hospital in the home because our nurses are going out to see the patient. So it's very easy for them to connect with a device. We can see patients well, so that actually really works quite well for us. And in Australia, it's already good evidence that it's been used with good clinical outcomes in bone and joint infections in Indigenous and remote areas. In endocarditis, as we say, we usually try and get them into our clinic and see how they're going because we're worried about those symptoms and we want to examine them. But maybe telehealth might be an option for if COVID-19 really changes and we need to have more of these patients at home and not coming into the hospital. And the other major problem that we had was TOE access and what we should do, because TOE is officially an aerosol generating procedure. And on patients who had known endocarditis with vegetations, we had a lot of trouble getting TOEs during the at the start of the COVID-19 peak. And so we had to look at alternatives, which included serial transthoracic echoes, and we had to carefully discuss with our cardiology and cardiothoracic colleagues about who they thought might benefit. So just to talk about the completion of OPAT, at the end of their care, I usually explain the plans for a repeat transthoracic patients want to know. Educate them about what the signs are to look for that the infection might be returning, because they're all very, very worried that it might come back, and what to do if they have a fever, which is basically to go and get some blood cultures taken and not to take any antibiotics until they've had the cultures. And talk to them about what the likelihood, because they're all very worried because they've had the nurses coming out every day and doctor visits and a PICC line, and then suddenly they feel abandoned because their PICC line's taken away and the antibiotics are stopped and no one's following them up. And so you've got to kind of make sure that they know exactly when their appointments are and what to do if anything changes. And I think I'll leave you with that slide. Asthenia or endocarditis. It's quite a challenge.
Thanks, Lydia. That's fantastic. Everyone's probably hungry for dinner, but maybe not now. So thank you for that. We've had a question come through, but we're going to save them all for the end. So we'll keep moving. Thanks very much. If Cindy Lau would like to get her slides up now. So if you stop sharing, that would be great. And Cindy can get her screen up and I'll introduce Cindy. So Cindy Lau is an antimicrobial stewardship pharmacist at St Vincent's Hospital in Sydney. Her research interests include clinical implementation of antimicrobial therapeutic drug monitoring and antimicrobial stewardship in immunocompromised population. And we're very pleased to welcome her to talk to us about the pharmacology of the agents we use for infective endocarditis. Thanks, Cindy.
Lovely. Thank you very much for the invitation to present tonight. And thank you also to so many attendees to making the time on a Thursday evening after work. It's really lovely to see so many of you. So thank you for making the time. So as we've heard tonight, endocarditis can be quite a tricky infection to treat. So my talk's going to cover specifically the PK/PD and TDM targets of our commonly used agents, the evidence behind them, and how we can actually use these targets to optimize our patient outcomes. I also wanted to focus more so on the practical side and how we can adjust our therapy to facilitate patients into the OPAT service. So these might include things such as how we can dose synergistic gentamicin, which has been mentioned already tonight, potential ways we can overcome dosing limitations in elastomeric devices, and finally, of course, the famous POET study, but I want to look more closely into the specifics of the oral agents chosen and the pharmacokinetics behind that. So to commence, when I think about endocarditis therapy, there's really three things I think that should be taken into consideration when we determine our antibiotic regimen. So the first one, of course, is the causative agent, causative pathogen, if we find one, and it's MIC. And this will dictate really the antibiotic spectrum that we need and the concentrations we might require to achieve some therapeutic effect. The drug itself, of course, will guide us, and the PK index, which I'll talk about, will subsequently guide us perhaps on the dose and the frequency and how we can optimize and monitor this. The bioavailability of the drug may actually also help us determine the route of therapy. And finally, the patient themselves, so the mug also. And not only the usual kind of characteristics as such as the pharmacist usually worries about, like a renal function or allergy status, but also individual factors and the complications that may alter the agents as well as the duration. So my presentation is going to focus on the bug and the drug, and I don't think I could present a pharmacology talk without going into this graphic, so bear with me a little bit. So this curve represents the concentration of an antibiotic over time in the patient after a dose of antibiotic is administered. And essentially this describes the pharmacokinetics of the antibiotics, or what the body does to the drug. We also need to consider the effect of the antibiotic on the pathogen, or the pharmacodynamics, what the drug does to the body. And this can be represented by the MIC, the minimum inhibitory concentration, which is the lowest concentration of an antimicrobial at which a pathogen is no longer able to grow. And you can see how it's represented on this graph as a dotted line. So neither the pharmacokinetics or the pharmacodynamics alone are sufficient to kind of predict whether antimicrobial effect will happen. But when we combine these two parameters, the quantitative relationship between them is what we know as the PK/PD index. And this relationship can kind of help us predict how well an antibiotic will work against a pathogen, as well as help minimize the incidence of side effects potentially, as well as the emergence of antimicrobial resistance. So the reason I go through all this kind of this graph essentially is because each antibiotic is associated with a PK/PD index that is best describes its antimicrobial efficacy. So we have, of course, the time-dependent antibiotics. So the effect is most dependent on the duration the concentration remains above the MIC of a targeted organism. And this, of course, is our famous beta-lactam group, and which, of course, is a very important group for endocarditis. We then have the concentration-dependent group, where optimal killing is achieved with the higher concentrations in the serum, and the prolonging these high concentrations actually has no beneficial effect. So historically, antibiotics such as aminoglycosides are thought to be in this group. However, there are very limited indications left where peak-guided dosing is used, and more recent studies suggest it's more of an AUC to MIC drug, which is when both time and concentration is considered to be important. So the reason I go through this is that knowing which PK/PD index to target for the antibiotic you're using may help determine how to use these antibiotics for maximum efficacy and what concentrations might be required. So going into more detail of the common antibiotics that we use for the treatment of endocarditis, I've got to talk about the beta-lactams first. And I just want to acknowledge that there are so many different PK/PD index targets that we propose, with each study investigating different clinical outcomes or microbiological outcomes. But for severe infections, I know I tend to occur on the conservative side and support that an unbound concentration should be maintained at least 4 times above the minimum inhibitory concentration for the entire dosing interval. I do want to acknowledge this quite recent study actually by Jason's group, which proposed that a new target of a trough to MIC ratio greater than 1.3 was a significant predictor of positive clinical outcomes in patients with gram-negative bacteremia in the intensive care setting. So I think that's really quite exciting and really could revolutionize how we dose our beta-lactams for gram-negatives, so watch this space. So Therapeutic drug monitoring, or TDM, is when we measure a concentration of the antibiotic in a patient and we adjust the dose to try and achieve these PK/PD targets. And I wanted to clarify straight away that there's really no great studies investigating therapeutic drug monitoring specifically in patients with endocarditis, and most of the evidence is really in the critically ill population. But given really how severe the infection can be and how severe the consequences can be if it's mismanaged, I think that it's fair that we can extrapolate this evidence into this patient group and should be certainly considered. So the TDM targets in beta-lactams are probably less well defined because of how safe they're considered to be in the wide therapeutic window. But we can extrapolate our targets based on what we know as the PK/PD target. So for example, if I was treating a Pseudomonas endocarditis, which I know is very rare, which had an MIC of 8 to piperacillin, I would target a trough or steady state concentration greater than 4 times 8, so 32 milligrams per litre. The fraction of the drug that's actually not bound to plasma protein, so the free concentration, is what the proportion of the drugs that's available to distribute into tissue, and is usually considered to be the proportion that determines efficacy. And so as such, ideally we should be using free concentrations when we monitor our antibiotic therapy. However, I do acknowledge not all labs are able to measure the free concentration, as it is more resource intensive and technical limitations may be a cause. So instead they will report on the total concentration. And in this case, what we usually do is you can calculate the free proportion using the published protein binding percentages and to try and estimate the free concentration. But there have been studies to suggest that using this estimation is quite different to the actual measured free concentrations, especially in highly protein-bound antibiotics. But there are no clinical outcomes really to show that that makes a big difference. So that certainly should be, I consider it to be better than nothing at all. Okay. So vancomycin, I think everyone's a bit more familiar with, and it's an area under the curve to MIC ratio drug, where bactericidal efficacy is actually proposed to be best when a ratio of 400 to 600 is targeted, and also suggests a reduced likelihood of acute kidney injury. Just to bear in mind, this target is mainly derived from retrospective observational studies and really only validated when the MIC of the pathogen is 1 and nothing greater. There is one retrospective study specifically in endocarditis that suggests that an AEC to MIC ratio of less than 600 is associated with an increased risk of treatment failure in MRSA endocarditis. And so we would certainly be dosing to that higher target. Just to note though, in our therapeutic guidelines, the current version, a trough of 15 to 20 is currently recommended for intermittent dosing when we monitor vancomycin. And the reason for this is because it's proposed that it's a reasonable surrogate marker for the AUC. However, there are increasing suggestions that that is actually not as great a surrogate as we think, as there can be really quite a wide range of area under the curve numbers compared when there's the same trough concentration. And as such, even in the more recent North American updated vancomycin guidelines, it does strongly recommend that area under the curve to MIC ratio guided dosing should be performed rather than using just simple trough concentration. I understand, given the technicalities of estimating an area under the curve, such as increased sampling and I guess the need for calculation of the area under the curve can be tricky. But given the wider availability of dosing software, I think that's something we need to start coming around to, particularly in serious infections. I just also wanted to mention the 20 to 25 milligram per litre steady state targets for continuous infusion is obviously something that needs to be known for, especially in OPAT, where continuous infusions are required. But bear in mind that the targets are extrapolated from intermittent dosing. But on the brighter side, it's very easy to calculate an AUC when it's a continuous infusion if you multiply your steady state by 24. So that's always a perk as well. All right, and the final class I'll go into more detail about is the aminoglycosides. And our therapeutic guidelines does suggest still that the empiric therapy when for endocarditis is still is still dosed to cover gram-negative pathogens, which is usually recommended as a AEC to MIC ratio of 80 to 100 for gentamicin and tobramycin. But it does acknowledge that monitoring usually is only required when therapy goes beyond 48 hours, and usually that's quite rare in endocarditis to be using gentamicin for such a gram-negative cover gentamicin for this prolonged period, as there's much better options available. aminoglycosides do certainly still have a role in synergistic therapy when used with beta-lactams for the treatment of streptococcal enterococcal endocarditis. And in this indication, AUC monitoring is not required because it may perhaps be more towards a time above MIC kind of antibiotic. And so therapeutic drug monitoring is performed purely more so from a toxicity perspective. And as Dr. Upjohn mentioned, keeping a trough of between 0.5 and 1 or less than 1 where possible is what is recommended. So now just kind of keeping all this pharmacology in mind, I wanted to now touch on more the practical side of optimizing antibiotic therapy in endocarditis patients in regards to OPAT. So to give you a bit of context, I work with a wonderful hospital in the home team at St. Vincent's, and I really do enjoy the problem solving that sometimes really is required to adjust an antibiotic regimen to try and help facilitate transition to OPAT. So some of these limitations might include, I'm sure it's not unique to our hospital, is that when it's obviously when they're in the home, there is a reduced frequency of how often healthcare can be provided. So for us, we only have once daily visits to home from our nursing staff. And as such, adjustment of administration of therapy as well as sampling may need to be adjusted to accommodate this. There have also certainly been times where patients have required antibiotic doses that go beyond what's actually available in the commercial elastomeric devices, and that's been a fun challenge to see how we can overcome that. And finally, with my antimicrobial stewardship hat on, there's always that question of, does this patient actually really need IV antibiotics in the first place? And are oral antibiotics an option? So I'm sure our challenges aren't unique, so I wanted to go through how we manage them in our hospital. So as I've already mentioned recently in the last couple of slides, gentamicin is used for synergistic, mainly gentamicin acetate, but synergistic therapy when treating streptococcal and enterococcal endocarditis. And the combination is shown to improve clinical cure rates essentially, as well as bacterial counts and vegetations. And when gentamicin is used for this dose, the latest editions of the therapeutic guidelines still does suggest multiple daily dosing, so of 1 milligram per kilogram of 8 to 12 hourly. And despite all, the big European and the North American guidelines suggesting now moving towards a once daily gentamicin synergistic dose, the therapeutic guidelines mentions that the small studies and animal data is not enough to say it's as effective as multiple daily dosing. I'm aware that sometimes when we can't use gentamicin, ceftriaxone as a synergistic agent is also an option. However, the twice daily dosing that it requires, again, is not really helpful in our OPAT setting. So I wanted to look if we could find a solution in, I guess, the biggest of the small studies that were available to look into. And I suppose this one kind of caught my eye. So it's a randomized clinical trial that compares the safety and efficacy between once or twice daily dosing of gentamicin in patients with endocarditis. And the primary outcome being the incidence of nephrotoxicity in regards to the absolute and percentile fall in renal function by the start and end of therapy. And the secondary outcome being more efficacy and looking at infection parameters and improvements. The patients were randomized to either receive twice daily or once daily 3 milligrams per kilogram dosing, or in divided doses in a 24-hour period. And the team did do some excellent therapeutic drug monitoring. So doing quite extensive sampling of troughs, so targeting a level of less than 0.5 with a dose adjustment between 0.5 and 1, and then withholding the dose if it was greater than 1 milligrams per litre. So it found that despite being quite a small study with 71 patients randomized, and despite being a significant drop in renal function within the group, there was no difference between the groups in the renal function at the start and end of therapy, and there was no difference in efficacy outcomes. So while there are small patient numbers in this study, I think it's quite suggestive that daily gentamicin still might be an option. As Dr. Upjohn mentioned, it's still probably not used commonly given the toxicity concerns, but if we really had to, that would certainly be something to consider in OPAT. Another problem we often run into when we're getting endocarditis patients ready to go is that we find that they require higher antibiotic doses than what's actually available in commercially available elastomeric devices. And this commonly happens with us in regards to flucloxacillin in our endocarditis patients, and where the maximum dose that's available in the device is a 14-gram device over 24 hours usually. So there are a couple of potential solutions we thought about. So of course, the obvious thing, having 2 devices at one time with running 2 obviously is quite sometimes inconvenient, obviously very expensive, but also usually does require dual lumen PIC, which obviously increases the risk of complications, as Dr. Upjohn said, but also it's also poor vascular access team. If you've ever had to ask them to replace a PIC to a different lumen, I'm sure you don't want to repeat that like I don't. There's also the opportunity to, I guess the other option is to keep a patient in inpatient, which is obviously not a good intention. But finally, we had a creative thought of whether we can try and reduce the renal excretion and prolong the duration of therapy that way. So probenecid is what we know usually is a gout drug, and works, can actually reduce the excretion of acidic drugs like penicillins and prolong the duration of therapy and increase the plasma concentration. And probenecid is not a stranger to hospital in the home therapy. Of course, we're very familiar with it using with cofazolin for the treatment of cellulitis. But if you look into whether it's been used with other beta-lactams or intravenous beta-lactams, you actually have to go quite far back into these amazing papers from the 70s and the 80s, and which are suggestive of efficacy, but there's really not much in the literature since to see if this is a good option. So we looked back at the times where we've tried using oral probenecid in addition to intravenous flucloxacillin therapy to see whether this will actually make a difference in regards to concentrations of flucloxacillin and whether we can get around this maximum of 4 gram elastomeric device, and as well as its clinical outcomes. So of course it's a very, I have to acknowledge it's a very quick study. It was a very dirty study. And so you can see each line here is a trajectory of 1 patient course. So you can see roughly there's about 7 patient courses here with the total flucloxacillin concentrations that were monitored with, and as well as over time with the day 0 lined up to when probenecid was commenced in these patients. So as I said, there were many different factors and very messy data where there were lots of different doses of fluclox and probenecid and administration. But what was kind of encouraging was that when we lined them all up, and you can see that there's a general trend towards an increase in plasma concentrations of flucloxacillin when the probenecid was commenced. Out of our 7 patients, 5 of them achieved a clinical cure. 1 absconded, unfortunately, after 5 weeks of therapy, and 1 developed a rash and required change. And we're not quite sure whether that was from the fluclox or the kepazole or the probenecid. No patients had any other substantial increases in LFTs or creatinine, which is kind of promising. But of course, we have to limit the obvious is that it's a very small case series, but certainly suggests if we're really quite stuck, it might be an option to increase flucloxacillin concentrations and facilitate OPAT. So finally, I wanted to talk about the POET study, which again, Dr. Upjohn has already talked about, but I wanted to focus more on the oral agents that were chosen, because I think it's really quite interesting what was done. So the oral antibiotic regimens that were developed were very specifically allocated by the trial investigators. And they made sure essentially that each antibiotic that was chosen had very good published data to suggest good to high, moderate to high bioavailability. The dosages that they used also based on pharmacokinetic calculations and expected UCAST MICs. And also they always made sure that there was dual therapy and both agents were from different classes, different mechanisms of action or metabolism, to essentially make sure if one wasn't working, the other one was probably going to help. And what I really liked about this study is there was quite an extensive pharmacokinetic aspect, and the patients were sampled quite well and to make sure the plasma concentrations were being therapeutic, and the dosages per protocol were to be adjusted if they're required. They did publish the cutoffs that they used to determine pharmacokinetic targets, but it wasn't quite clear where they were from. So just to show you from the supplementary material, these are the agents that were recommended, and these were the targets that they were using for as a therapeutic target. So the results showed from the pharmacokinetic side that only 7 patients did not achieve therapeutic concentrations, and that was only ever in 1 of the 2 antibiotics that were used, and the other antibiotic always had a therapeutic concentration. But interestingly, the regimens actually weren't changed based on these results. Encouragingly, the primary outcome did not occur in these patients that didn't achieve therapeutic plasma concentrations, and there was a similar incidence of adverse effects in both groups. So the investigators concluded that they did not consider pharmacokinetics to be a factor when offering antibiotic therapy if the randomization criteria were met, 2 antibiotics with good bioavailability were prescribed, and the patient's GI uptake was considered to be normal. And I'm not sure if I'm interpreting this right, but I do think that's quite a bold claim. So as you can see to the right, it's a very strict cohort of patients. There's quite a lot of exclusions. So the generalizability of this statement to a wider population may be quite tricky and might require some further investigation. And as I said before, you've probably noticed in my slides before that the evidence for PK targets is not always really quite easy to extrapolate. So I would have really liked to have seen how the targets had been determined in more detail. But as Dr. Wee said, I'm thrilled to hear that POET2 will have a closer beta-lactam therapeutic drug monitoring arm. So I'm really looking forward to seeing how those results go. So I think in conclusion, how I take away from this is the oral transition, earlier oral transition is certainly beneficial in the right population. However, I do think the repercussions of mismanagement is certainly too risky to take, and therapeutic drug monitoring should be considered. And I just wanted to put this slide at the end to show it's quite a useful spot where if you look on the ASA website, you can actually see which labs are available to perform which assays, if that helps, and also their contact details. So in conclusion, endocarditis is a severe infection, and I think it certainly warrants optimization of antibiotic therapy. And while clinical outcome evidence may not quite be that yet in this population, when the repercussions of the mismanagement are so significant, I think it seems logical to really think about the PK/PD indices and TDM. Transition to OPAT may require some adjustment of antimicrobial therapy, and so some potential solutions to meet these limitations might be things such as once daily gentamicin for synergy, perhaps Benacid to go around flucloxacillin maximum concentrations, and finally oral transition earlier in therapy is likely to be effective, but we should probably consider therapeutic drug monitoring to make sure they are therapeutic. Thank you.
Thank you, Cindy. Fantastic talk again, so thank you for that. I'll let you drop off the share screen and Mark will dial on there. So while that happens, I will introduce Dr. Mark Lowenthal, who's the Director of Immunology and Infectious Diseases at John Hunter Hospital in Newcastle. Mark has an interest in hospital in the home and outpatient antimicrobial therapy, and he is the Medical Director of their Out and About program at John Hunter Hospital, which started in 1995. His other interests within infectious diseases are bone and joint infection, tropical medicine and HIV, and he's been asked to speak on infective endocarditis in vulnerable populations. Thank you, Mark.
Hi, can you hear me okay?
Perfect.
So thanks for inviting me, and can I say how much I've enjoyed the presentations so far. I don't think you'll find much overlap between my talk and everyone else's. We've got a very large program here. We've actually recorded 465 admissions to our OPAT program for endocarditis treatment, which is probably 400 and something patients. And I have to acknowledge the other people who's contributed to this presentation I'm going to give, and you'll see it's a multidisciplinary team, 2 infectious disease doctors, 3 RNs, and 2 addiction medicine specialists. I'm really going to focus on the use of OPAT for treating people who are IV drug users. And I'm actually going to present our data on everyone who's been using every known IV drug user who we've admitted, not just endocarditis. Looking at that 465 endocarditis patients, only 39 of them were recorded as being IV drug users. And in total, I'm presenting data on 178 known IV drug users or injecting substance users, as we're now supposed to call them. I just quickly looked at our database to see that we're up to 184 now, so we seem to have added 6 since this data was accumulated. But you can also see, because the denominator is about 7,000, that firstly, the patients that we take on are selected, and the IV drug using patients that we take on are selected. And interestingly, it turns out when we look at the hospital's IV drug using population, that they're strongly selected even before anyone refers them to us. And so there seem to be a reasonable number of people who've got a history of IV drug use, who have infections, who are never referred to us, and we think we could probably help some of them. I want to quickly add that there isn't a cardiologist listed there, but that's not because we're neglecting the cardiologists. It's definitely a team. Endocarditis management definitely requires a team, and everyone admitted to John Hunter Hospital is assigned an infectious disease doctor, a cardiologist, and a cardiac surgeon, in theory, from day one. And our policy is that everyone has a case conference with all of that group. I can tell you that doesn't actually always happen, but I think the involvement right from the start of everyone is very useful, particularly the cardiac surgeons, who we've found give us much better service if they know about the patient from the beginning, and they get grumpy if the patient's already been sitting in hospital for a week and we're asking them to operate sight unseen. Okay. Sorry, I'm just trying to page. Doesn't seem to be working. So I'm just trying to go to the next page, but it doesn't seem to work. I might just close the presentation and go and open it again and see what happens. Hang on. Right here.
Thanks, Mark. While you're doing that, I'll just remind all our participants, there are a number of Q&A questions that have popped up. So if you see any that you like, please vote them up by clicking the thumbs up, and we'll get a flavour of who's interested in what. So there you go, Mark, you're up and running.
Right, yep. Okay. Going since 1995, I arrived here in 1997, and we'd just been giving IV ganciclovir at home before then, but we've moved to just about everything. And the other thing I want to talk about is a tool that we've invented, and we'll come to that. We're running a bit low on time. I'll come to that a bit later. But we put together a tool for assessing people who have a history of IV drug use. Sorry. All right. I think I seem to have jumped ahead a lot of pages. Hang on. For some reason I seem to have jumped a long way ahead. Here we go. Okay. Mostly elastomerics. I'll just go straight past that. Yeah, so we looked at all admissions and compared the outcomes between IV drug users and non-IV drug users. We put together a database in 1997, and every patient who's been on our home IV program is on that database. So we can at least pick up everyone, even if all the information isn't there, but then we can go to the record and see if we can get that. For this study, we looked at a number of things. We looked at what we call non-compliance, and that was the expression used in our problem record on our data collection form. The patient was counted as non-compliant, and it's probably no longer a fashionable term, but they weren't available when the nurse visited, they were uncontactable, they didn't turn up for the medical review, and we review, like Lydia's service, we review people every week, or they wouldn't come in when we told them they needed to come in. So that's non-compliance. We classified the patients with the help of the drug and alcohol team with current last 3 months, use recent, and distant use. The classification that turned out to be a lot less useful than we thought it was going to be when we looked at the data. And bloodstream infections, standard criteria. Okay. starting in 1998. And I would say that when we first presented data in 1988 on IV drug use in hospital and the home, it was sort of met with shock and sort of apoplexy amongst the people we presented it to. But that's gradually changed over the years. Oops. Yep, so lots of admissions and 164 admissions, 125 patients for IV drug use. And like with infections generally, and all data I've ever seen from hospital home programs, more males, there are more males than females for just about every serious infection. As it turned out, the IV drug users were on the program for slightly longer, just we've got quite big numbers that turned out to be statistically significant. So it's not as if they were just on the program for a short amount of time. People were on the program for a median of more than 3 weeks. And the conditions in many ways mirrored the overall things that we treat people for. So we run infectious diseases service. There's a separate service that also does outpatient antibiotics for a short period. So really we look at the people who have been referred to infectious diseases who are having long courses of antibiotics, and that's bone and joint infections, endocarditis, and then other things. The only really big difference is there's a lot of people with cystic fibrosis amongst the non-IV drug users. And the vast majority had PICS. We also run the PIC service, so outside of critical care. So we don't have a big problem getting PICS into patients. All right, so that's the patients we looked at. We compared the non-IV drug users to the IV drug users. Probably won't be surprised to see that if you looked at what was called non-compliance, that was somewhat higher in the IV drug using population. 6.2% had something recorded in the data collection sheet versus not much more than 0.5% for the non-IV drug users. So all those things, not being there when the nurse arrived, not coming in when we asked them to come in, not coming in for their appointments, were all more. Interestingly, and I can't give you an explanation for this, but the people who were most likely to be non-compliant actually weren't the recent ones. It was actually the ones who had the history of having used IV drugs in the past. I can't give you an explanation for that, but at any rate, and really at any category, people who had a history of IV drug use were more inclined to upset the nurses, I guess is a better way of putting it. All right, the other thing that we do, and for people who run hospital in the home programs, this is something to think about. For the first 2 years of running our program, a successful treatment meant that you came to the end of your course as prescribed, not whether you got better or not. So looking back on it at that time, we thought, well, that's fine, but really the ultimate thing is whether the patient gets better or not. So we now, one of the 2 infectious disease physicians in the program documents what they consider to be a success for that patient down the track. Initially, it was a free text field, and then after a year or so, we collected the common things into a sort of drop-down list. So, but the idea was that you had to decide before you followed them up what you're aiming to do. And these are then assessed by the research nurse who looks at all the records, contacts the patients, and assesses whether the patient met our original criteria for a success or not. And that's very useful. And actually, if you ask the average cardiologist, and hopefully Yong will tell me that's not the case with him, but if you ask the average cardiologist or cardiology service, how many of your patients with endocarditis get properly better? If you ask really anyone about anything they treat, how many of your patients actually get better? Often as doctors, we don't have an answer to that, whereas we can give an answer as X many percentage of our patients actually get better, and it's assessed down the track at arm's length, so you can't sort of make up whether they got better or not. Once you hear the story, you've got to have decided prospectively. Okay, so this is the data on success. So interestingly, although IV drug users might have been more non-compliant, virtually everything else was the same. Early discharge from the program because of a problem, same. Readmission rate back to hospital, the same. And long-term success, 78% in the IVDU, 80.5% in the non-IVDU. Sorry, I don't actually have the endocarditis figures there. They'd actually be a lot higher, and I think most OPAT services will have the same experience in that by the time the patients get to receiving their OPAT, they've gone past the most critical period for them to get complications. And we've only ever had one actual death on our program, even though now we've had about 8,000 patients. Another interesting thing is that IV drug users are more likely to use we've got a 24-hour on-call service, and more likely to, and it follows from that, more likely to have an after-hours call out to fix a catheter-related issue. And I'll also say that 42% of our patients overall are actually self-administer their drugs, which is highly skewed towards the cystic fibrosis patients, but we don't let the non-IVDUs anyway administer their own drugs, so that if the dressings are being tampered with, and that's not recorded by the nurses, then we would know who was doing that. Okay, so overall, despite the fact that they might have made our nurses a little bit more unhappy, they did just the same. And in fact, when we looked at our endocarditis patients and compared them with other endocarditis patients, exactly the same. Their overall rate of complications was no different whether they have IV drug users or not. Slightly more catheter complications, whoops, sorry. But no more bloodstream infections in the IVDUs. So that was interesting. And when we first presented on IVDU, people said, look, they'll inject things into their lines will get blocked. That doesn't seem to be hugely the case. And the other thing is, if you look close enough at your patients in hospital who are IV drug users who have PICC lines in, a significant number of them are actually taking advantage of that opportunity in the hospital itself. Okay, let's summarise and we'll quickly go on to our tool. So in our cohort of highly selected IV drug users, and selected, as I say, before they even get to us, and then selected by us and drug and alcohol. And the other thing I'll say is that initially drug and alcohol and ourselves weren't on the same page, but that's been a good experience, and we've now moved. So that originally the drug and alcohol people said they didn't want anyone to go home with an IV device, but we sort of convinced them around, and now they're part of our team. I think the rest is covered in our tool. Yeah, so it's both the inpatient team and potentially other HITH services in the past have expressed to us that they're not keen, although I think that's changing over the years. All right. So our aim, as with every patient, is really we want to give them the best possible treatment, whether that's in the hospital or the home. Everyone really has to be assessed. Everyone who's got a history of IV drug use needs to be assessed by alcohol and drug service. And we aim at harm minimisation philosophy and a non-judgmental approach. I think I'll leave the oral versus IV. I mean, other than to say, if you think a person is, whether they're an IV drug user or not, if you think they're not going to be keen on hospital in the home, they may also not take their tablets. I might just flick through these in the interest of time. But we're interested in patient safety and staff safety, major potential issues. But having said that, those are issues in plenty of other HITH patients other than the people who are IV drug users. And as Lydia says, really, staff safety is, in fact, the #1 priority, I'd say. Yeah, I think I probably put these in for to say it's a general issue for visiting, including rural properties, dogs, whatever. Okay, so we drafted up an original based on sort of experience and what the drug and alcohol people said. We put together a pilot. We ran the pilot for a set of objective criteria, and came up with a great acronym, as all studies seem to have. Hang on, let's go through those quickly. We included a whole series of factors, both from the drug and alcohol people and from what our experiences were. And these are going to all be reflected in the tool that I'll show you in a minute. And in fact, over my practicing lifetime, the most commonly used injecting drugs have changed from opiates to methamphetamines, which have their own issues. Yep. Okay. So here's our Start ICU on HITH, our screening tool assessment risk to intravenous substance users on hospital in the home. And we scored, after the pilot, we scored each of these factors with a different number. I'll give you a chance to have a look and see what's there. As you can see, the very first one, sustained admission, only got a 1 because if you looked at our figures, that actually was not really predictive. But clearly, use of amphetamines got a slightly lower score than use of opioids based on the details I haven't presented of the previous study. And the highest scores came with patients where they'd been found in the ward intoxicated or slurred speech with a reduced conscious level, and or whether when they threatened staff and shown aggression. And you can see That's all the bottom of that, but really we're looking for scores of 8 or scores of less than 8 to get onto the program. Or sorry, a score of 8 or higher would indicate substantial risk for admitted to HITH. So you can see people who threaten violence don't get onto our program on the whole. And similarly, if they've clearly been intoxicated in the wards, that's sort of almost an exclusion.
Mark, just in the interest of time, are you happy to share that tool?
Yeah.
How can people contact you for that, or should they contact your service?
Yep, they can actually send us a. Oh well, maybe if I send it to, maybe if I should send it to you, and can we do that? And,
Yep. So we can facilitate that afterwards, perhaps through CRE REDUCE. That's fine.
That's it, and we've great, and we've supplied it to the hospital and the home, the Australasian hospital and the home group as well.
Yep.
And look, we'd be happy for people to use it and evaluate it, because it's only halfway through its evaluation phase at the moment. Okay.
I'm conscious, Mark, that I've got a burning list of Q&As there.
Yeah.
Well,
yep,
so
we're almost done. So I guess we could summarise by saying, in-hospital compliance is a good pointer to potential HITH compliance, and the advantage of having a tool that's sort of documented in the notes. The idea is it's not a totally subjective decision. So I guess I could summarise by saying we've looked after lots of people who are IV drug users. You will find that the history of IV drug use makes people more likely not to turn up for their appointments. But that was actually overall, non-compliance was only 6.2% of patients. And overall, they do just as well as their non-IV drug using counterparts with the same infections. Thank you very much.
Thanks, Mark. Thanks very much. So we'll arrange to make some contact available so that if people want to see the tool themselves, it is available through the Australasian Society of Infection, the HITH Society of Australasia's website, and we can make that directly available in the future. Now, our panel are all there. Some of them are on mute and some of them are hiding, but we'll get them to open themselves back up live, and I'm going to throw to them without too much notice, so be prepared. I'm actually going to throw this one to Yong, actually. Yong, one of the questions, would it be preferable to start infusions and monitor the TDM levels as an inpatient before people go to OPAT? That, in my experience, hasn't historically been the practice. Would it make more logical sense if we started using infusions on the wards rather than just when they switch over?
Well, at least from my experience here, I mean, it's all guided by the ID team. They generally review the patient and then they tell us what to do.
Maybe I'll jump in there. Look, I really like the idea of starting the infusions in particularly vancomycin infusions. If you can start the vancomycin infusion as an inpatient, it makes an easier transition with dosing. And changing from intermittent dosing to infusion dosing and being confident that you've got your level correct. So if your ward staff will accommodate an infusion on the ward prior to coming in, I like that idea. For other antibiotics, we don't necessarily do that.
We do it for vancomycin, certainly. Absolutely. We'll try and we're really quite strict when we try and transition people to OPAT that they have to have therapeutic concentrations for at least 3 levels. Yeah. So because we've just wasted so many Baxters before. We do flu clocks as well in the ward as well. So we have tried to stabilize people initially on a 24-hour infusion as soon as I know that they're likely to go into OPAT. And we do take concentrations to make sure they're therapeutic. And that's how kind of we identify our patients that might need more than the 14-gram
dose. I really like the idea. It's just making sure that the nurses are happy with you.
Yes. So we've got that prolonged infusion programmed into our pumps in the hospital as well, so they're well set up to do so.
So can I totally support that, but the only thing to say is that the look, if they're having trouble with a vancomycin dose, we just take them onto the program and adjust it ourselves rather than muck around in hospital. Yep.
As well, yeah. We don't want to delay them coming on, but we do like to get it started. If they're going to be, you know, if you see you've got a few days, you might as well you put them on.
Thanks. I think we're all in agreement there. It's a good idea, but we've just got to get on and do it. I'm going to throw this one to Sydney because it came out of your talk. You mentioned the maximum dose of Fluclox in elastomeric being 14 grams. What maximum doses do you require?
Yes, so our maximum dose is the 14 grams over 24 hours in an elastomeric device, because only more so that we're limited in our administration frequency because our nurses only visit once a day. So that's actually the limitation. We found in hospital that we do, like I said, some patients require more than that. I think I've gone up to 22 grams of flucloxacillin over 24 hours. But like I said, that's why we had to try and be imaginative and see what we could do to address this maximum dose.
Good. And Cindy, you're staying in the... Oh, go Mark. Yeah.
Can I quickly comment? So I don't know if you know, Cindy, we were going to be the control arm in the study.
Yes.
And, because at Sydney, really, everyone's so addicted to the idea of high doses of flucloxacillin that conducting a controlled study there was impossible. Whereas we don't routinely, we give much less fluclox and we don't routinely do PK on fluclox. But I don't know what happened to that. We had it all organised, but anyway, I don't know what happened.
Nor do I. Sorry, I'm not sure.
We wait
in anticipation.
And Cindy, you're staying in the hot seat because Chris from the UK has asked us a question. I think you alluded to that dilemma around stewardship and using narrow spectrum agents via less convenient methods versus broader spectrum agents that are more convenient, but obviously come at an antimicrobial stewardship cost. How do we come to resolve this issue?
Oh, I was Dr. Gilchrist. I knew this might come. First, I have to preface that I'm not an expert in stability. I'm terrible, but I'm not great with. Certainly don't know much more than the normal pharmacist about it. I guess how I interpret this question is that if we didn't have therapeutic drug monitoring, I guess, you know, and I think it comes actually back to what Mark was saying before about the need for clinical trials to actually show the outcome changes to be able to, I suppose, support whether one is better than the other. And that's just really obviously very difficult logistically to do. And I think that is what we require to get around that debate. I'm very keen to hear if anyone else has a opinion on this.
Lydia, do you want to comment from an ID physician point of view around the benefits of using the easier to use broader spectrum agents versus narrow?
Look, we would always try and, sorry, that's just my 2-year-old.
Yep, they do that.
We always try and go with the narrower spectrum agent as possible. Look, there's a whole lot of broad spectrum agents you could use. So you'd use penicillin via a PICC line rather than an oral switch to a broader spectrum agent? Correct. Usually, it depends on the clinical scenario. I mean, the common one that you have is should you choose between benzyl penicillin infusion or ceftriaxone on hospital in the home, which one would you choose? And I think that you should generally choose the narrow spectrum agent and do the benzyl penicillin infusion. That comes at a cost, so it's probably more costly to do a benzyl penicillin infusion. However, it's maybe a bit less convenient as well. So you've got to take in nurse time when you consider that. But pick the narrower spectrum agent.
Okay. Thank you. We could go around on that one all night, I'm sure. Yong, can I ask you, because a number of people are operating OPAT and hospital in the home services in more rural and remote areas. So when a patient from a remote area has prosthetic valve endocarditis, and you're obviously based in Brisbane and presumably drain a fair chunk of Queensland to your service. What do you do in terms of regular specialist input in OPAT centres in further rural and remote areas in terms of their ongoing specialist follow-up?
Well, we have a few ways to follow up the patient. I mean, basically, usually with prostatic infective endocarditis, the chances of them being not very sick is not very high, because usually if the infection is severe, they'll probably require another surgery. Only a very small percentage will end up skipping the surgery or any major operation to treat it, basically. So, I mean, we do telehealth, but it's not exactly ideal to follow up this sort of patient. And with the repeat echocardiogram and everything, it's better that we can compare side by side. So besides clinical, echocardiogram done at different places can be quite different. So we prefer to bring them to our hospital if possible. I mean, there's a few ways we can always keep the patient in the hospital. I mean, there's the nursing support, and then we have some arrangement that we can try to arrange to keep the patient around in Brisbane.
Very good. So I was going to move to are people using their hospital in the home services for patients being treated with oral therapies? So obviously the POET trial used these complicated drugs in terms of potentially side effects, toxicity. I can certainly comment that some jurisdictions, the funding restrictions around what's funded and what isn't is a problem in terms of a pure Australian hospital in the home model. But I'm wondering if others have found ways to follow in an outpatient setting through a similar sort of process.
We've never done that. We do have a category called the complex patient, and sometimes we can put patients funded onto hospital in the home as a complex patient for monitoring of blood. So we might be able to get around that way, but we've never actually done that. We would always follow them up routinely in another service in an outpatient clinic.
Mark, in New South Wales?
Yeah, look, the answer is the same, although that's something we've had. When the pilot study came out, we've had considerable discussion about it. And I must say we haven't actually treated more than a very small number of patients on one of the POET regimens, but I think if we start doing it regularly, we will have to follow them more closely than just giving the tablets and sending them home, that's for sure.
And I think there's no doubt the patients benefit from that structured system behind them that in our setting, hospital in the home provides, but in an OPAT setting would provide with that closer follow-up. So I've had a couple of drug-specific questions voted up there. So people using meropenem infusers and their stability, discuss.
We do use them. We use BD infusions. We've had good clinical success. We often use a level. And I think there's increasing evidence that it's meropenem BD infusions is perfectly fine. I don't know about really, really hot weather. Like if you have a heat wave, how you go with that. It should be kept at a lower temperature, I think. But good, we use it.
Mark? Look, there you go.
Yeah, we use it and we try and use BD infusions. We actually do sometimes do 2 grams over 24 hours, depending on the patient. But I would say, if I look at everything we do from a pharmacokinetic point of view, that is the most dodgy thing we do. It's really the only dodgy thing we do, I think. You know, because it does have significant hydrolysis by then. But when we look at our results, as far as you can tell, and a lot of the patients are CF patients that you can't tell, they seem to do fine. The other thing I'd say is that a lot of our cystic fibrosis patients and their families can be trained to give themselves intermittent dosing or BD dosing.
Yeah, and I can probably add that certainly I've had clinical success in a similar method, so that's fine. And we've had a comment also there that in Christchurch using them with ice packs. So I suppose that's the other, to try and keep the temperature lower. and to account for hotter weather, I suppose. Ceftriaxone, push or infusion for 2 grams and upwards?
We give it over an hour.
Push.
There you go.
Push.
So, yeah,
We put push.
okay.
It's a logistic thing for us.
Yeah.
Yeah. Yep. So I think, you know, logistic and experience issues with that.
Oh, can I say we give, it's really not so relevant in endocarditis because you use small doses, but we give tobramycin and gentamicin at any dose by push, and we published on that in JAC quite a few years ago. So you can give a huge dose, it turns out, of tobramycin by a push. And yeah, that's under my name and Pauline Dobson in JAC, Journal of Antimicrobial Chemotherapy.
Good one. All right. Cindy, ceftaroline, Fosamail for infective endocarditis.
I've fortunately never had the reason or need to use it. So I'm sorry, I don't know the answer. Like, anyone else?
Never used it. It's a broad spectrum antibiotic, and that's its advantage, really, isn't it, in MRSA infections where you need even broad spectrum gram-negative. Wouldn't really fit into the endocarditis category of treatment commonly or ever.
So I'm not sure whether we've, I assume we
Yeah.
probably haven't got a manufacturer representative, but I suspect there's probably not necessarily clear data for that.
Yeah.
There are some papers with moderate numbers of people in them showing reasonable treatment outcomes. Mark, did you want to?
Oh yeah, I mean, we've never used it on OPAT. We've used it for MRSA endocarditis under various conditions in a few cases, and that's all I can say. It's worked fine, but I never use it in OPAT. They've always been very sick.
Yeah. All right, and for the panel, I'll go to Yong first this time. The impact of COVID activities on the impact of COVID on your HITH activities in your endocarditis patients?
Well, as Lydia mentioned, I mean, the TOE, because it's quite aerosol, so it's actually quite complicated from our point of view, but obviously it's a discussion between risk versus benefit. So depending on how much the patient needed and how high risk is the patient from a COVID point of view. We did actually publish a guideline on our website, on the IEQ website, so feel free to have a look on there. But it's basically a risk versus benefit type of scenario. Like if we can avoid the TOE and patient's outcome is the same, we try to avoid it at least during the peak season. Now that everything has settled down, it's almost back to normal, but it's basically depending on how high risk patient is for COVID.
Yeah, so I found that guideline useful in terms of stratifying to TOE versus TTE. So
yeah, and sometimes you do discuss it in the MDT meeting as well, and depending on how people feel strongly about it, whether the surgeon wants it, the ID wants it, and then we're happy to consider as long as they are low risk from the COVID point of view. We are flexible.
We didn't have such flexibility at our hospital at the peak of COVID. And, you know, we're in Melbourne, so we've still got a lot of COVID, but even with 2 negative swabs, we had trouble getting a toe unless the head of cardiothoracics was going to operate and they were only going to do it on the table. So, yeah, I think it's a really difficult area, and we'll see what happens.
I'm sure every hospital is a bit different.
Yeah.
Lydia, while we've got you live there, so when you have issues with PICs and clamp bottles and things occurring and the lines are blocked, do you reload patients who are on continuous infusions?
We try to, depending how much time they've had off and what drug it is. I do tend to like to load them again.
Is that drug specific or all drugs? What do you do?
Vancomycin we reload, Fluclox will reload again. So it's drug specific. Yeah.
Mark? Oh, sorry.
Vancomycin, we would try and reload. Yeah, we wouldn't really Fluclox. It's a 45-minute half-life, I guess, with Fluclox.
Depends how long they've had off, you know.
Cindy, did you want to add to that?
I completely agree that it depends on the drug. So I think vancomycin as an ASU drug definitely needs to certainly be reloaded. But for beta-lactams, I'll probably be less inclined to reload as they'll get back to the steady state very quickly.
Okay. There's a question about switching over to oral therapy. I know we've discussed POET a couple of times tonight. Do we have kind of a oral switch regimen, a get out of jail problem strategy if we're having difficulty getting to that end of 4 to 6 week treatment? Is that something you've encountered, Mark, with, you know, what tips you over into switching over to oral where you're having difficulties?
At the moment, and it probably will change. I mean, POET was for me a very convincing study. At least if you had the, you know, they tightly selected their patients and all the things that Cindy said. At the moment, the people we've changed to oral, people we've had some sort of technical or practical difficulty with giving them IV, but we should, you know, I think in time we'll probably change that, and there'll probably more people who will need oral. We'll look to POET too as well. But I think we probably, you know, there's been a bit of a acceptance problem with all of us with the idea of oral therapy, but POET was quite convincing. So we'll see.
Good.
That's why I'm going to say watch POET too. I think it'll give us a better idea when it's published.
Yeah, I think that's good. Yong, while you're there, ECG monitoring. So we discussed tonight that after the first couple of the weeks, the risks have substantively diminished and people are managed in the outpatient setting. ECG monitoring down the track at week 2, 3, 4, 5, 6. Do you routinely do ECG monitoring? Do you do none? What do you do with that?
You mean ECG or echo?
Yeah, so it's a question, ECG monitoring in an outpatient setting, is there still a risk of abscess or arrhythmia, and is it significant after the acute phase?
Not routine ECG, but depending on the symptoms and depending on patient risk factor, I guess a lot of the drugs could prolong QT and things like that. So that's another thing that we might need to monitor, but it's very individual basis. So not as a routine, but case by case.
And you touched on it in your talk at the end of treatment, transthoracic versus transesophageal.
Yeah, I think there's no routine on that. It's all depending on the clinical scenario as well. I mean, we do bring our patient back between 3 to 6 months and repeat another echo, make sure they are doing well and no complication, but no hard and fast rule depending on clinical situation. Again, multidisciplinary team. If there's any particular concern on any part from our colleagues, we're more than happy to repeat either the transthoracic or TTE, that's right, transesophageal, anytime.
Okay. Couple of questions there on gentamicin. So when using it for synergy or having relatively low or undetectable levels at the standard dose, do we increase the dose until we see a trough level? Mark's shaking his head. Lydia?
I generally don't. I'm just happy if it's less than 1 and they're not getting toxicities. Yeah.
Yep. And
I'm happy when I can't detect it. Yes.
Yep.
And there was a study from a really long time ago in the 70s where they actually looked at, I think it was 2-hour post, or might have been 1 hour post, and they showed that, I think they showed that a level of 3 to 5 was just as good as a higher level in that particular circumstance, completely different from treating gram negatives. And the other thing to say is that we use much less gentamicin now than we did in the past. And even though we would say with enterococcal endocarditis, we should in theory use it first line, once we look at the patients who get enterococcal endocarditis, they're old, they've got renal impairment, they've often already got hearing impairment. So really now it's actually a small minority of our enterococcal endocarditis who get more than a small amount of gentamicin, and they get gefraxone, which we may just give once a day after about 2 weeks. Yep.
Okay. Cindy, how often should we monitor the gentamicin drops?
I usually, as Mark said, usually the duration is actually quite short. by the time they get into OPAT. So usually I suggest at least twice a week, but that's just completely off, not evidence-based, and it's just more from a convenience perspective.
Yeah, and that's our non-evidence-based approach.
Correct.
Lydia? Lydia, are you doing a couple of times a week?
Yes, that will be standard. It's not very common. It's we're not using it as much, and as Mark said, you know, our patients often have renal impairment, and we just avoid it.
Okay. And I'll throw to the panel in general. Patients needing ceftazidime via branded elastomeric infusers. What are people doing where patients need ceftazidime?
Very common use for endocarditis, ceftazidime. That's a general hospital in the home.
Yep. Someone snuck that in, yeah. Cindy, any advice there?
We don't use ceftazidime elastomeric devices due to the data suggesting it's unstable and with, I believe, byproducts that we're not sure about. So usually, especially with our lung transplant team, we'll teach our transplant patients to self-administer as a push 3 times a day. Yeah, that's usually how we get around it.
We do.
Yep, we stopped using it.
Of ceftazidime, and we haven't had problems with the toxic metabolite causing.
Okay.
Yeah,
Jason,
we gave tons of it for years and years, and actually, when Josh Davis was in Darwin, actually published and showed there didn't actually seem to be a clinical problem, but it's just a nuisance now, and we stopped doing it.
Jason, I haven't made you answer anything. Do you have a comment on that one?
No, just that my experience is consistent with the variability of responses so far, that some people are happy to use it and others just have use a provider who won't provide it, so they don't use it anymore, essentially.
Okay. We're down to the last couple and then we'll wrap up. Mark, drug levels on the injecting drug use patients in your OPAT service? Do you bother? Do you not?
No different from anyone else. Where we don't routinely do flucloxacillin levels, and obviously we do. Vancomycin levels essential that you monitor.
Yeah. Okay. All right. We may leave it there. We've got a few thank yous there in the comments as well. So thank you, everyone. I'd like to thank everyone who's joined us. I'd like to particularly thank our speakers, and I'm going to throw to Jason to finish off.
Well, thanks, James, and to the panel. I think that they were some wonderful presentations. Don't think it could have gone any better to what I was hoping to get out of it personally, and I hope that for the attendees that they similarly got really good value out of the messages and the learnings that came through from that. So we will be in contact with all of you again soon to let you know about our next webinar that we're planning, which will be in about 2 to 3 months' time, and hope that you'll be able to join us for that then. Again, I'd like to thank our sponsors, MSD, Pfizer and Baxter, for facilitating us being able to provide this to you tonight. And on behalf of everyone here, wish you a very good evening and enjoy your dinner. Bye.
Thank you. Bye-bye.